different departments within the health region. We have one from Mamawiden and one from the doctor's clinic. So the objective of our team is to reduce add-ons in ambulatory care. Another sub-objectives that we have is to decrease patient movement and also to decrease providers' movement and setup time. In this endeavor, I would say we have talked to three major physician groups: the gynecology group, the ortho group, and the GPs within our city. We've also tried to reach out to 59 clinics, out of which we did 43 clinics all in all. We also talked to different departments within our health region as well. Just to give you a background, the add-ons for ambulatory care is 30 add-ons per day, and the capacity of ambulatory care is 7. On this slide, this is the VSM, or the value stream mapping. We focused on the CAS clinic, showing that the patient goes to, from registration, the patient goes to ambulatory care, may need to go to x-ray, see the ortho doctor or the ortho technician, and then be discharged. The takt time for the entire department ambulatory care is 7 minutes and 43 seconds. For CAS clinic alone, since there's 2 clinics per day, per patient, our takt time is 12 minutes. Okay, this is our target provision. Since we are focusing on decreasing add-ons, patient movement, and providers, I want to emphasize the patient walking is 800 feet per each patient, and we want to decrease it to 400 feet. For advanced booking or is 30, and then we want to reduce it to 0, like no add-ons possible. Please. And we want to reduce the setup time in the CAS room from 29 minutes 53 seconds to 15 minutes. And I will give the floor to Ali.
Hi, I'm Elaine. I'm with the OR Scheduling Office, and I book the ambulatory care procedures. We've never really had any continuity in when things arrive and how they arrive. I have several different clinics that I book for, and some of them would send me stuff well in advance, some of them would send them to me during the night for the morning of. We've now changed that, and your cutoff time is 2 p.m. the day before the appointment. I need to have that information. We will also now be blocking some appointments to accommodate any add-ons that we unfortunately will still have. But in order to accommodate those, we will block certain sections throughout the day for those patients. The ortho clinic will now be booking CAS clinic. I don't know ortho, I can't tell you what procedure takes how long, and at least their office will be able to know which is a long treatment, consult, so that they don't run over at the end of the day. And just an example of how things will be blocked, just to leave spots. In the scheduling office, I received a multitude of different types of booking forms, and we have now changed that. This is just an example of what the forms look like. And if you're someone new that's just coming in, it's very difficult to locate the information that's required to book those appointments. We've now gone to a standardized form. If an office has capacity to print that, they can just send me that. If they don't have it, we have a template for them. They can put the information in and send that in.
I'm Colleen Brown from one of the medical clinics in town. Elaine and I approach as many medical clinics and private practices in town to update the changes that are going to implemented, and also look for input from them. We've received positive input with the reduction of paper, doubling up and faxing and everything, a lot less info being lost or not sent, so that was a positive. We didn't receive any negative. Everybody was glad to get rid of the 3 different types of booking forms. So this should help with less faxing for Elaine, the communication between the departments, and the low leveling, which we are all trying to do, so it's less information out there, less chance of everything getting lost.
Good afternoon, my name is Jackie Woodard and I'm a registered nurse that works in ambulatory care. The movement of our CAS clinic patients in our system we thought was a bit confusing, but that's how it was always done. Now I want you to put yourself in this scenario. You've hurt yourself, so you go see your family physician. He thinks maybe that you have broken your ankle. So he makes arrangements for you to see the orthopedic surgeon in the CAS clinic at the Victoria Hospital. You are given crutches. You come to the hospital, you proceed to the admitting department where you are told, please go to ambulatory care. In your journey to ambulatory care, you're thinking, I was told to go to the CAS clinic. There is no signs to tell me where to go to CAS clinic. When you get to the department, you are greeted by a nurse and you are sent to the x-ray department as you need an x-ray. Once you get to the x-ray department, you may have to wait there. Then you are sent back to ambulatory care to tell the nurse that I'm back. You are then directed to the waiting room where you wait till you are called back into ambulatory care to an examination room and see the orthopedic surgeon. There, the orthopedic surgeon will discuss your x-rays with you and your treatment. You need a cast. You are directed to the cast room to sit in the waiting room till the technician can put the cast on. After the cast is on, you are directed back to ambulatory care desk so you can get your follow-up appointment. 800 steps and 2.5 hours later, you are exhausted, you are cranky, you are sore, and you are thirsty. Meanwhile, while you are in this process of getting yourself looked after back at ambulatory care, the orthopedic surgeon is having a CAS clinic, 25 to 30 patients he's seeing. There's only 4 rooms. Meanwhile, there's the internist. He's doing a bone marrow. We have the general surgeon. He's seeing his post-op patients. He's taking a room. We have the ET nurse who's doing a complex dressing. She's in one room, and that patient needs to see ACAP. There we have the lone orthopedic surgeon calling in the patients to one room himself. And he doesn't know that he should change the sheets in between the patients either. And the nurse, who is trying to direct traffic, answer the phone, and make appointments for CAS clinic patients, is interrupted. So that CAS clinic patient is still waiting to get that appointment because that nurse, she's being pulled, but her hair is still intact.
Good afternoon, I'm Justin Galloway. I'm the RPIW participant from home. And in addition, I guess, to what Jackie was sharing is that the original flow of this clinic required the patient to take 800 steps, and we managed to reduce that with this new flow to 504 steps. So there's a difference of 296 required from that patient. So you can see when they enter the hospital, they register and they walk directly down that main hallway. In front of that foundation office is where we placed the CAS clinic desk that is housed by the nurse. And then we've also taken the colposcopy clinic and put up a barrier and put 2 ortho beds in there as well. So rather than having to use the ambulatory site on the far end of the clinic, we're able to do it all near that CAS clinic. So we have the CAS clinic, the nurse, and some of those clinician rooms all in the same location. Out in the hallway of the main hallway, we actually have some waiting chairs. And it was also identified that as patients were coming to the nursing desk, it was a lot easier to instruct them to go to diagnostic imaging straight down the hallway and return without having to have gold sheets or even actually walking them the full distance there. So. This is a picture of the modified room where we actually have put up a room divide and 2 beds for the ortho appointments. We've also, if you want to flip that, we've actually relocated the colposcopy clinic to one of the clinic rooms that's located behind ambulatory care. I believe it was clinic room 1 where they're starting to pilot the use of that space with those style of clinics. In addition, in our CAS clinic room, there was a storage room or supply room that had a lot of inventory that wasn't used on a daily basis. A lot of stock that potentially could be stored elsewhere or even to explore maybe moving it off-site. So the team was able to do a lot of work to the point that by moving some of the stock or inventory downstairs, also making some items potential to be shipped to third world countries, it allowed us to physically remove one entire shelf that is in the room. The floor is completely open, and it worked out to be a 20% improvement to space availability in there. And it's also opened up the opportunity to look at that room as a potentially another ortho room for these clinics. These are some of the items that were identified as potentially being able to go to storage and those third world countries. And this is an after shot of that clinic room. Another piece that what came out of this RPIW was to look at the amount of time that it took that ortho tech to restock and set up for those patients that you see. Part of the hope was to improve patient flow throughout the day and in turn improve the time that he can actually spend with those patients and less time required to restock and set up. So there were time observations taken, which allowed us to be able to create a standard work combination sheet and and our percent load chart. So it typically would take that ortho tech 189 seconds to do setup for each of those patients. After changing the flow of this clinic, we were able to reduce that to 18 seconds for each patient that you saw. So it's sharing some of those roles and responsibilities with that nurse that is located outside or just outside the room. She was able to look after a lot of those x-ray referrals.
Hello, my name is Donna Cook and I'm with the Kaizen Promotion Office and I'm a participant on this RPIW. So we found that for the ortho tech or the ortho nurse, that there was no standard word for how they process and admit their patients. So we developed standard words, and it does say that when the patient arrives, they look at that pink sheet and then they have to sort out if they need an x-ray or where they're going exactly. So that's all now on standard work. We also developed frequently asked question information sheet for all of the patients who come to the ortho clinic. because these are questions that they tend to have frequently. And on there, we do tell them that their appointment may take 1 to 3 hours. We're hoping that that time will decrease, but just giving that information up front so that they're not surprised by the length of it, and then they're also not interrupting, asking how long and how much longer, and so on. And this sheet was part of the test that was given to the admitting clerks to let them know about the redirection of the patient, so they weren't going to ambulatory care, they were just going straight back in that step-saving moment. We tested this yesterday and we surveyed quite a few patients. I can't remember how many, but we added up all these, at least 21 patients, to see how they liked this new process, and they mostly liked it. There were still some remarks about some of the wait. It's still a long wait, and needed more chairs at X-ray. You can see them on the bottom. We had an idea sheet come in that's saying that there is no signage throughout the hospital, but ambulatory care, CAS clinic, and so we worked on some signage for staff and patients. This is showing a picture of the nurse at the desk and a sign showing the CAS clinic. This is showing, you can see the signs are against the wall and also sticking out from the wall. So if you're sitting across, you can see, and if you're looking down, you can see as well where you need to go. We added signs for the cafeteria, elevator, diagnostic imaging, and then back to the main desk, because we heard several patients say, how do I get out of here? This is when you come into the hospital, so that you can see ambulatory care, CAS clinic, endoscopy, all the same way. Another sign by the volunteers desk, because she would often get interrupted to ask where the cafeteria is and the elevator. And this sign was just for patients as they were registering, so that they knew we had a new process for them.
Great, this is me. So hi, I'm Edson. I'm no longer page flipper. I'm from Kai's office. So this is the SPD sterile processing department room within ambulatory care. So as you can see, they had stuff piled everywhere. Cupboard doors were closed. If you go to the next picture, these are more of the items, and only in 2 of the shelves that they actually used within SPD. In those other shelves you saw open, those are all ambulatory care supplies, so we moved those out. And I lost my projector. So there is another, the next picture. Next picture here, I'll just hold it up and you guys can look from a distance. As you can see, it's much brighter from a distance. And so we took out all those. Every time I do a 5S, it's always brighter, so I don't know that. But so we kept some of the cases there. Those were all empty cases, so they didn't need them right in the room. All the SPD supplies that they use on every cart for all their scopes is right here. It's all in this one spot. It's a little understocked at the moment because this was near the end of the day. But they can grab all this and just flow from there rather than having to go all over the place. We also we also freed up space so that we could lower all the shelves because many people are vertically challenged. So we made it lower so that you could get it gloves right away and all those other things. And the doors are out of the way too. So we got rid of 6 high shelves and we got close to our target of the score. And then these are just all the targets from the sheet. So the main thing I'll point out is how much we reduced the walking and the setup time. So there's some pretty big reductions there. Go to the next one. And so just showing the different times. Some of our times didn't change because we couldn't affect, say, X-ray and things like that. But lots of progress with class.
My name is Ken Weiss. I'm a frequent flyer of the health system, and sometimes I'm the patient representative, and sometimes I'm the inpatient representative. Workshop summary. We decreased the walking steps for the CAS clinic patients. We increased communication. We decreased the paperwork and paper waste and booking time for the scheduling for the scheduling clerks. Reorganizing and increased efficiency of the CAS clinic flow, both for patients and for staff. Doctor participation and input was included in this process and very much appreciated. Regardless of the depth of responsibility or participation, all people involved contributed to the success of the RPIW. In particular, we would like to mention Sheila Long, Cecile Hunt, the ortho department, gynae department, Dr. Royapan, Dr. Dale Ardell, Corinne Hack, Cynthia Narita, Yoko, our translator, Arigato. Val Isbester, Boris Bisky, the maintenance department, environmental services, both really deserve an extra thanks because they were there. Right now, we had a major change that hadn't been planned, and they cooperated very well and did it all. Diagnostic imaging, the patient registration desk, when we asked them to give out extra papers along with the pink sheet, they were more than happy to do that. The day surgery staff, absolutely amazing simply because they have an extra 10 people and they're beside the patient getting in their room. IT, the physician clinics, the ambulatory care staff, the foundation office, and all team members for that matter of RPIW number 6. All the patients who allowed us to be a part of their journey. And I guess the last one, this is my 3rd workshop, and I would like to say congratulations, Cecile. You and your management team are a credit to your profession.